I'm so excited for our last presentation. This is one of my favorite presenters, and so I'm so excited to introduce and welcome Lydia Bartholow. She's here to talk with us about addressing stigma and bias across care settings. So welcome, Lydia.
Thanks. I'm so excited to be here with you guys. I didn't really know what to expect today, and I feel like I way overdressed and way over-prepared, because turns out I know all of you, and you're all like my best friends, and I didn't need to wear high heels. I don't know if I ever need to wear high heels, but definitely didn't need to wear high heels today. So I'm going to be hanging out with you guys for the next hour and 15 minutes or so, and we're just going to be talking about stigma. And much like the high heels, I really feel like we could just be having a conversation about this. I'll probably go through the material pretty quickly, and then we can just sort of converse and chat about it a little bit. It's pretty interactive. In fact, it's very interactive. We're going to be talking about stigma and bias across care settings. I don't have any disclosures. And I'll just tell you guys a little bit about who I am for those of you that don't know me. I'm a psychiatric nurse practitioner. I have sort of a specialty in addiction medicine and co-occurring disorders. And then I kind of have like an academic interest and academic specialty in trauma-informed care for substance use disorders specifically. Right now, my clinical practice is at Unity. This is a big transition. Probably most of you know me from my work at Central City Concern as a medical director. I'm also a person in long-term recovery, so when I'm talking about stigma and trauma-informed care and substance use disorder services, I come at it from the standpoint of being a clinician and an academic to a certain extent, and also a person with lived experience. I went through substance use disorder services. I've been through those services, and I know what it's like to be stigmatized, and I know what it's like to do things and engage in care that can sometimes be re-traumatizing. So today, my primary objective for today is just that we start a conversation about stigma. I want you guys to understand how impactful stigma is in the realm of substance use disorders, and we're going to sort of focus in on youth. And I want you guys to understand how we think about the layers of stigma. I want you guys to be able to identify the 3 layers of stigma and how those affect our clients. And then I also want to make sure that we highlight how stigma shifts depending on someone's identity. So let's say that you are a Black gay man who's using substances. The stigma that you face is going to be very different than someone like me going into substance use disorder services. And before we dive into those objectives and before we sort of dive into some of the didactic material, let's do some intention setting and sort of highlight a practical takeaway that I want you guys to be carrying with you as we move forward. So first, I want you guys just to spend a moment and think about why you do the work that you do. Just take a moment and think about what values guide the work you do. All right, so what are some values that come up for you in thinking about your professional work? Integrity. Love it. Yeah, having integrity.
Community.
Great. Community.
Service.
Providing service.
Love.
Love, absolutely. It's an underpinning of trauma-informed care, to love people. Compassion. Love, compassion, service, integrity, community. I love that you said community, because I'm like, oh, look at us today. This is good community. I walk in the room and I know so many of you. Anything else you guys want to add to the list?
Hope.
Hope, yeah, absolutely. That's a great one for today. And how many of you are clinicians? Okay, the vast majority of you, which is what I thought. So you're going to bring all of those values, or at least most of them, into the work you do with clients. And this is a little bit of a trick question, but just bear with me and see if you can guess what I'm going for. As a clinician, what's the thing that you need to do to bring all of those, to bring hope and community and integrity and compassion? Yeah.
Presence of self.
Presence of self. Yeah. Rest. Ah, so many good things. I hadn't thought of any of these, but yeah, absolutely. You need all of these to bring those things. I'm always like the mushy, ushy, gushy talker. Pretend for today that I'm not. And someone was like, what do you do to be a good clinician for substance use disorders? And I'm not the ushy, gushy talker. Pretend that for today. Do you guys do evidence-based practice? Yes.
Time.
You do need time, yep. And you definitely need time to do evidence-based practice and compassion and love and integrity, absolutely. The thing I want to zoom in on, though, just for a second, is evidence-based practice. How many of you guys consider yourselves to be stewards of evidence-based practice as you work with your clients? That's not nearly as many hands as I thought were going to go up. Now I want to deconstruct that, but we don't have time. But if we do have time, we'll come back around to it later. And here's why I bring it up. There is nowhere other than SUDS where we engage with non-evidence-based practices so freely. And for the most part, that's based on stigma. So as we move through today, I want you to think about the values that guide you in your work and the ways in which stigma might interrupt you from enacting evidence-based practice. Does that sound all right as we move through this? Just keep it in mind, like keep it in the back of your head, because it will be one of your practical takeaways. All right, so first, I want you guys to tell me someone from media, and I'm going to give you more instructions, but just bear with me for a second. Someone from the media that are portrayed positively and have or had a substance use disorder. And when I say media, what I mean is a fictional character, movie or TV. Not Hunter Biden. Fictional characters, movies, television, portrayed positively. And when I say positively, here's what I want you guys to take into account, because people are always like, House. And I'm like, whoa, to me, he's not portrayed positively. He's incredibly smart, right? But he's pretty selfish. He's pretty self-involved. So when I say portrayed positively, I want you to think about someone who's not portrayed as being selfish, who's portrayed as being able to recover or has recovered, and is not, their like identity as a character is not interwoven with criminality. Who you got for me? Ooh, is there a new season out? Oh my God, I'm so far behind. Okay. I think that probably is totally true. Reservation Dogs. I haven't seen the new season, and it's been a minute since I saw the first season, but that makes perfect sense to me. I bet Reservation Dogs. Yep.
Cookie Monster.
Okay. All right, we'll take it. Oh, yeah. Yeah, okay, New Amsterdam. Yep, how many of you have seen New Amsterdam? Some of you, okay. I love, the shows you guys are bringing up are great. Reservation Dogs, New Amsterdam. What else do you want to throw in the bucket here? Cheers. Okay, that's great, because I was going to ask you to roll the time machine back and look back further in time. Cheers is certainly further in time. I can't think of anyone that has a substance use disorder in Cheers, but it's been a long time since I've watched it. They do? Ted Danson has an alcohol use disorder? Oh, he is? He's in recovery? Oh, cool. Okay, he's the bartender and he's in recovery. Got it. Okay. All right. How many of you guys had a hard time thinking of someone? If I ask you guys to make a list of people that are portrayed positively, and then I subsequently asked you guys to make a list of people that are just portrayed as having a substance use disorder in any variety of ways, how much longer would the second list be? It's really, really hard to find representation of substance use disorders in a way that is portrayed positively. It absolutely exists. We could spend the next hour talking about it, but it's incredibly hard. And something that I want to call out is that the first two things that were mentioned were made in the last 3 to 4 years. My favorite representation of substance use disorders has been in the last 4 years. This Is Us. This Is Us does a great job of representing substance use disorders. People are portrayed not selfishly. There's a lot of recovery demonstrated. It's pretty incredible, actually. And that's brand new because we are in the midst of a cultural moment where we're conceptualizing substance use disorders differently, right? It's much harder to go back. I didn't know about Ted Danson. That's super useful. I remember the first time I ever saw someone portrayed as being in recovery, and it brought me to tears because I had never seen myself reflected back before. And it was West Wing. And I was like, oh, look, I'm just like those guys. Oh, wait, I'm not like those guys at all. It was confusing, right? So we'll come back to that. Okay, so the takeaway here is you have not had, throughout your lives, you haven't had a lot of positive portrayals of substance use from the media. How do you think that impacts how you think about substance use disorders?
Judgmental.
Might make you more judgmental, totally.
People who haven't experienced it feel more biased towards it.
People who haven't experienced it feel more biased towards it. Yeah, it's interesting because I think that's true. And from working in this field, what I also know, and as someone in recovery, what I can also tell you is that people in recovery sometimes are the most intensely judgmental because they've made the change. And it's hard to remember that time when you were pre-contemplative. It's hard to remember why. And I say that as someone in recovery. Anything else that you think about when you think about how much this may have influenced your thinking?
It makes me think that that it's more difficult to call to mind what positive perceptions of recovery would look like.
Oh, interesting.
How could it look good if we're not seeing it, like that kind of sense.
Yeah. Like what would representation look like? Yeah, absolutely. Yeah.
Or
Yeah.
just possible at all.
To represent it positively?
Well, to recover, right? If you don't ever see people portrayed as being in recovery, or it's not talked about.
Yes, yeah, absolutely.
And that it's like, can it actually happen?
Oh.
It's hard to remember that it can't.
I just want to take your words and blow them up on the slide. If we don't see representation of people in recovery reflected back in common cultural narratives, we're less likely to think recovery is possible. When the research is pretty clear that people recover. In fact, a lot of people recover without services. A lot of people recover without services. It's pretty incredible, actually. All right. So let's then pivot, and we're just going to do a quick lit review of how impactful stigma is. So I pull out this journal article. It's pretty old at this point. It's from 2014, but it was, I would say it was transformative in how we thought about what barriers were to accessing substance use disorder services. And it's old, so it talks about substance dependence because it's using DSM-4 language. So it's a little funky. But here's the conclusion, and this is a meta-analysis, so kind of a big deal. It's not one opinion piece, right? This is a meta-analysis. Conclusion, stigmatization was the strongest predictor of substance dependence. Anti-stigmatization, prevention, and outreach programs are needed to overcome the reluctance of this clientele to utilize healthcare services. So what they're saying that they found in this meta-analysis is that people experience stigma in a variety of different ways, people who are using substances, and were less likely to access services around substance use disorders or any type of healthcare really because they perceived stigma. And they didn't necessarily use those words, but the people that were using substances didn't engage in recovery supports because they felt judged, because they felt less than, because they felt like they were going to be treated poorly in recovery services. Does that ring as true for you all? I hear it all the time from clients and patients, how poorly they've been treated by the healthcare system. I was just on Kaiser yesterday. Does anyone else have Kaiser? Oh, wait, I shouldn't call out Kaiser. Sorry. It's phone trees. It's just medical phone trees. It has nothing to do with who the provider is. It's medical phone trees. And I was in tears. I was like on the phone 20 minutes with the referral coordinator who couldn't make a referral to yada, yada. And I was in tears. And I was just thinking about how hard that would be if all I wanted was to stop using opioids. And I was trying to make that phone call. And what if the person wasn't that kind to me at the same time? So what this is saying is stigma is the biggest predictor of substance dependence and people not engaging with services. This one, we zoom forward a little bit, but very similar outcomes. Stigma as fundamental hindrance to the United States opioid overdose crisis response. Public stigma and enacted stigma can become structural stigma. We're going to come back to that. When they become encoded in cultural norms. Ooh, why do you guys think we talked about media and cultural narratives? Because this stuff is often invisible and it gets encoded in cultural norms, laws, and institutional policies. Collectively, these forms of stigma run at cross purposes and reduce public support for public health-oriented policies to address the opioid overdose crisis. So this one is specific to opioids, but I would say that the findings here can be pretty general. And they really build on that article from 2014 that says this is a primary reason that people don't engage in services. What this is saying, people don't engage in services, and stigma is bigger than people just not engaging in services. Stigma is also about what services get built, how those services are billed, how easy it is to access medications, right? That stigma shows up in all these other different structural places. And don't worry, we'll come back, because some of you guys might be a little bit confused when I use the term structural, so we'll come back to it. But it's just saying that stigma is so big, it's infiltrated the systems, including our cultural narratives about substance use disorders, and that really impacts health outcomes for people that use drugs. That's what this one is saying. All right. I want to, actually, I'm going to skip this one just for the sake of time. This one is an opinion piece by Nora Volkov. So like, no big deal. We don't really care about her opinion, right? Who's Nora Volkov? Yeah, she's the director of NIDA SUDS. So she's kind of a big deal. She's pretty brilliant. She says, stigma not only impedes care delivery, it also most likely causes us to underestimate the burden of substance use disorders in the population. But stigma plays an even larger role in this crisis, one that has been less discussed. When internalized, stigma and the painful isolation it produces encourage further drug taking, directly exacerbating the disease. And I love this piece because she's, again, building on what we've already talked about and saying, and then there's this other piece, it's structural, it's in these cultural narratives, it's impacting all parts of the system. And then she's saying, and the neurobiology of stigma and shame actually make people more likely to use. So we're getting hit from all sides, right? Stigma's so big, it's infiltrating all these different places. And in some ways, most interesting for us today, although it's not the only thing that I want to hang out with, is that the research says that people who use substances avoid healthcare and engage in all kinds of behavior to avoid being stigmatized in healthcare settings. So we have all these stories we tell, like, for example, that people with substance use disorders lie. That's a common cultural narrative. Addicts are liars. It's part of the disease, right? My patients usually don't lie to me unless they have something to lose. And when people come into care, one of the things they feel they can lose is our respect. So people are going to tell us narratives that don't necessarily line up with other things, because people engage in various behaviors to not feel judged or to avoid health care, or to feel like they're getting adequate and fair health care, et cetera. And when I say health care, by the way, I'm including substance use disorder services. All right, so We took if you dive into the stigma literature, you will find hundreds of, around substance use disorders, you'll find hundreds of thousands of journal articles. I pulled out a couple of the ones that I think are the most salient and the most important, and also help us to understand all of the ways that stigma shows up. So let's do a quick review of the 3 types of stigma. Remember, one of our objectives was that you guys are able to identify 3 sort of types or layers of stigma. Let's start with structural stigma. What do you guys think that means?
Is that the same as like the bigger societal stigma?
Yeah, that's the same as the bigger societal stigma. So when, in this setting, when you hear me use the term structural, I am not talking about buildings. I'm talking about structures that exist and are often invisible and reinforce things. This is a term that comes from Paul Farmer. How many of you guys know Paul Farmer? Oh my gosh, that's like only a couple hands. You guys. You are in for the treat of your lifetime. Like all of you that don't yet know about Paul Farmer and you're about to go Google him later, you are going to be so excited. I'm so excited for you. Okay, so Paul Farmer is this physician, did a lot of public health stuff, and he, in the 70s, started to identify that health outcomes really had very little to do with what he did in a one-on-one patient encounter. That health outcomes were really about these like larger systems and structures. And his term for it was structural violence, essentially like when structures don't meet people's basic needs and that hampers their health outcomes, that's called structural violence. He's an amazing public health theorist, like he's really incredible. So when stigma researchers talk about structural stigma, and this isn't, by the way, this is not me like pulling together Paul Farmer and like some ideas around stigma. This is very well like research documented. There's this thing called structural stigma. And it's when the cultural narratives inform policies, funding streams. It's when the cultural narratives that we carry around inform how many treatment centers there are for youth substance use disorder in Oregon. That's about stigma, right? It's a very real, important thing to treat, but we don't have any treatment services for it. What's that about? In part, it's about structural stigma. Because our structures haven't supported that, they haven't funded that, they haven't built that, etc. So that's what structural stigma is. And it's kind of a big deal, and it's a little bit hard to talk about and locate and name. Can you guys think of some examples of structural stigma that you see? Sending people to prison instead of treatment. It's a health problem. But the prison system in the US is the #1 SUDS treatment center, which always blows me away. Yeah, good example.
I feel like something, it's hard to name, but something.
It's hard.
Yeah, the lack of like medication-assisted treatment for people under 18. And
Yeah.
detox services.
Yeah,
Why isn't there a place for detox?
yeah,
Especially teenagers.
yeah. Why isn't there a place for withdrawal management services for teens?
Or an after plan.
Or an after plan. Would we ever do that for, what's that? What? We would never do that for Hunter Biden, it's true. I mean, I think sometimes when I think about, would we ever do that, what's really useful for me to think is like, would we ever do that for someone that had a heart attack? So someone has heart disease and a myocardial infarction, all the things you guys are talking about, like is there a specialty treatment center? Is there an aftercare plan? We would never let someone just like leave without an aftercare plan and be like, cool, go to some meetings, good luck, right? We might if they were poor. But with SUDS, we do it all the time. We're like, cool. All right, well, here's a list of AA meetings. Hope you make it to one. Good job, right? I mean, we do this sort of like bonkers stuff in SUDS that we wouldn't do in other places in medicine. Any other examples that you guys want to highlight of structural stigma, especially as it relates to substance use disorders?
Low pay for drug and alcohol counselors.
Low pay for drug and alcohol counselors. It's a paraprofessional, right? We don't have to pay them that much. Yep, absolutely. And indeed, when I bill, for the most part, when I bill under a psychiatric diagnosis, because my specialty is co-occurring disorders, if I bill under a psychiatric diagnosis, my reimbursement is higher. At least from my understanding. I don't actually do the billing, but this is what I've heard from the billing department. So yeah, that's structural stigma, right? With the assumption that it's somehow easier to treat opioid use disorder than major depression. All right, so structural stigma gives way to interpersonal stigma. What do you guys think interpersonal stigma is?
Someone like assuming that you are a godparent or caregiver because you deal with addiction.
Yeah, it's the things that happen interpersonally. So it's when you have a substance use disorder and someone automatically assumes that you are not a very good mother, or that you're not a very good father, or not a very good parent. It is when you have a substance use disorder and so you go to the hospital for pain and people think that you are looking for a substance when maybe you're actually in pain. Interpersonal stigma is the thing that happens between two people, and it's reflected within structural stigma and often enforced by structural stigma. But it's when people that use substances experience stigmatization. And oftentimes, folks don't have the words for it. I certainly didn't when I was experiencing it. And oftentimes, we don't know that we're enacting it. But it's there. Have you guys heard of some examples or think of things? Nothing super personal or super intense, please. But, yeah.
I think there's sort of an overarching belief that I've experienced, especially when in systems or fields where there's sort of this high achieving, sort of intelligent mindset that anyone that's in the struggling with addiction is lazy.
Yeah. Yeah, the assumption that someone that has a substance use disorder is lazy or unintelligent. Yep.
Just a reminder, we need the microphones to get to you before you answer the question, or we won't be able to hear it.
Oh, okay. Is it okay if I state it back?
You're doing an awesome job.
Okay.
But sometimes when it's a longer question,
Okay.
We have this, story.
I'm glad.
We have this story around substance use that people have to hit rock bottom, and we would never say that about somebody who had suicidal ideation, for instance, right?
Yeah, that is so well said. We have a cultural story that you have to hit rock bottom, but we would never say that about heart disease or suicidality, right? Because what is rock bottom in SUDS, heart disease, and suicidality? It's death. And dead people don't recover, and they are members of our community, and they are fathers and mothers and sisters and daughters, right? Yep, absolutely. And then we treat people differently based on that, right? Okay, so then structural stigma gives way and intertwines with interpersonal stigma, and I really want you guys to be thinking about how this shows up in healthcare. And then those make way for self-stigma. And we talked about self-stigma ever so briefly, but let's review again. What is self-stigma?
I think it's the internalized stigma people give to themselves from what they've gathered from outside
Yeah,
things.
absolutely. So if I really needed to repeat it this time. So it's the internalized stigma that people give themselves. That's what self-stigma is. And it is essentially it's how you would start to feel if all the structures around you treated you like you didn't deserve things and weren't worthy of evidence-based practice or access to certain things, and if all the people around you treated you differently based on your substance use disorder. Of course, you would start to think these things about yourselves. Not to mention the often multiple failures you experience in your life because of symptoms of a substance use disorder. And the real bummer here is that the neurobiology of self-stigma exacerbates the disease. So do you see how we've created this like really complex puzzle where everything is connected and pretty hard to address? It's gotten big and messy. There's these big structural things based on narratives, and then people's neurobiology shifts based on that. It's really tricky. And so I want you guys to think just for a second, how do you think those cultural narratives and the way that this all fits together, how do you think that might prohibit us from enacting evidence-based practices for substance use disorders? What are all the things? If we think about all the things happening here, these 3 layers of stigma, how does that prevent us from engaging in evidence-based practice? I see a hand.
I mean, I just think we're working on this cool project right now around pregnancy and SUD, and we don't even see these people in clinic. Like, they're not showing up for treatment. So they're not even there to get the practice that we know works.
Yeah. So what I hear you saying is we can't even do the evidence-based practice because people don't show up. And what the literature says is people don't show up because they fear how they're going to be treated. Or that's part of the reason, I should say, that a big chunk of the reason people don't show up is they fear how they're going to be treated, what their experience is going to be like. And honestly, I can't imagine being a pregnant person using substances and asking for help. I can't imagine what that would be like. It is hard for me to tell you all that I'm in recovery. I can't imagine being pregnant and asking for help around substances. Oh, it just sounds so hard to me. So yeah, I wouldn't show up. I don't go in for pap smears. I'm not gonna show up for that. No, absolutely not. I'm glad that this was a mostly AFAB audience and you thought that was funny. Thank you. Okay, so I want you guys to be thinking about, how stigma is gonna show up and influence evidence-based practices. What's one more way in which stigma is showing up and potentially impacting evidence-based practices?
We can't hire enough providers because we pay them less and there's less value placed on doing substance abuse treatment. And we think it's harder to do substance abuse treatment.
Yeah, so because of structural stigma, we pay SUDS providers less. And because of that, we can't hire them the way other places can. So we're pretty chronically understaffed, right? Community SUDS treatment, even before the pandemic, was often understaffed. And now, woefully so. Yep. Great, good. I'm glad you guys are seeing the way that these things show up in your day-to-day lives. Super useful. Next, I want you guys to go back to thinking about people in the media. And again, this is fictional characters. I should probably change these slides to say fictional characters. And now I want you to see if you can think of someone who's portrayed positively and is a person of color. You guys, this silence is incredibly painful. It does exist. But I only know it exists because I look for it constantly. I've got to the point where I don't watch TV anymore. I only watch TV when people tell me like, oh, so-and-so's in recovery in this show. And so that's what I'm going for, not the relaxation part of TV.
Morgan Freeman is God.
What is that? I don't know.
Yeah. Morgan Freeman has played God at least twice, I think.
Got it. Does he have a substance use disorder when he plays God? Oh, sorry. Oh, God, I'm sorry. No, okay, we're doing the same exercise that we did before, but we're looking for characters of color.
Same answer, reservation dogs.
Okay, reservation dogs.
911 actually has 2 people, and one's Caucasian and one's African.
And they're portrayed positively?
I would say so. One does relapse, though.
Okay.
I don't know if
It totally does. It does. I mean, if it's showing people recovering, Totally. Okay, 911.
Yeah, it's good.
I'm putting it into my mental Rolodex
Captain
of things to
Nash
watch.
is the main one, and he actually gets into firefighting because he ends up like relapsing, but he gets back into it after he is recovered again.
Got it. Okay, cool. I'll try to watch it. 911. You guys think I'm here to decrease stigma? I'm actually just here to get my next television list. Yeah, there's a hand in the back.
Euphoria, the lead character, and then she at one point, I think they still communicate, had a sponsor that was African American and definitely portrayed positively.
Totally, Euphoria. Great example of portraying positively people with a substance use and people using substances, and they're people of color. And it's from the last 3 years, because we are in a cultural moment where we're understanding addiction differently. Try to find one from 20 years ago. Super hard.
Dr. Weber on Grey's Anatomy.
Oh, okay, this is a new one for me, which is weird because I thought I knew most of Grey's Anatomy, but clearly I don't. Dr. Weber is a person of color?
Yes.
Okay, I'll have to go back and watch. How many of you guys know Dr. Weber on Grey's Anatomy? Oh. Oh.
It's super prevalent. He's a recovering alcoholic, always talks about going to meetings and all of that, and like encourages other people to go to meetings with him, and yeah.
Sweet. Okay, 911 and go back and watch Grey's Anatomy again. On it. Anything else you guys can think of? Was it harder to come up with this list? So what is the point of this activity? What are we highlighting that we want to be thinking about specifically?
Underrepresentation in media.
Yeah, I don't know who just said that because I don't have my glasses on. Underrepresentation in media. And I want to specifically to just take a moment and acknowledge that many of the media portrayals that we've gotten of people of color who use substances are directly linked to criminality, which has to do with structural stigma. Remember someone brought up prisons earlier? So there's sort of an invisible structure here holding up this idea that people of color, we tend to think like people of color and white folks experience SUDS at the same rate, but there's certainly is this sort of hidden narrative that people of color are criminals when they use substances. How many of you guys grew up watching Cops? Cops was like always on at my house when I was a kid, for reasons I don't really understand. I think it just was something that was on after school was out. So what this means is that sometimes our clinical decisions are going to be influenced by structural stigma, and sometimes they're going to be sort of doubly influenced by structural stigma and invisible cultural narratives around race. And it didn't have to be race that I talked about, although I think it's incredibly important, especially when we're talking about substance use disorders. But I could have asked you guys, if you can think of an LGBTQ character with decent positive representation of a substance use disorder or recovery. And it's trickier. And again, there are some, but it's often in the last couple of years. Although I think that one's a little bit harder because we haven't had very much representation of queer folks that are portrayed positively up until more recently anyways, right? That's just the reality of it. Okay. I want to hear from you guys just a quick reflection of whether it is useful and eye-opening to think about media portrayals that you've gotten. Has that been useful in thinking about like, whoa, maybe my brain has been sculpted and I wasn't aware? Yeah? Okay. Cool. Later, I'm going to come back and say, what's your takeaways from this? And I would love if there's some takeaways from media stuff. All right, so this is just highlighting that what we just talked about it really holds up in the evidence that folks of color experience much more stigma in healthcare settings And so when they also have substance use disorders, they feel like there's sort of a double whammy, that they are mistreated in healthcare settings, and especially so if they have a substance use disorder. And actually, someone brought up New Amsterdam. And if you haven't watched New Amsterdam, they do a couple of amazing episodes about racial disparities in care in major hospital systems. That's totally, I mean, I wouldn't say it's evidence-based. It's not like it's got references at the end of the episode, but it reflects what the evidence says about racial health disparities in hospital outcomes. So when folks of color are experiencing poor treatment in healthcare, it certainly holds up in the data that we have. All right, so let's pivot now and just talk briefly about youth specifically, because I realize I've been giving you this sort of very conceptual overview of stigma and how it might be influencing your work in ways that are often invisible, but let's think about it for youth. What do you guys think? If we were gonna add some bullet points, and we've kind of already done this, but if we were gonna add some bullet points under structural stigma, what would be specific to youth?
With the way that the legal system is set up, needing to have parents involved or being a mandatory reporter, and that being a barrier to youth being able to disclose information safely.
Yeah, absolutely. The way that things are set up, because of the legal system and the necessity of mandatory reporters, it makes it so that it's very hard for youth to be transparent about substance use.
So we have the stigma that people shouldn't use drugs, and youth definitely shouldn't use drugs in the dominant narrative.
Yes, people shouldn't use drugs and youth shouldn't use drugs. And what happens to the youth brain when you say don't use drugs? Oh my God, give me all the drugs, right? What if we said drugs are really, really risky, you might do them, here are safer ways to do them? Guess what? Evidence says that that is how you talk to kids about substance use to make them not use drugs. When we tell youth not to do something, they want to do it. Those executive, that whole prefrontal cortex, it is primed to push back. Let me say this differently. It's not big enough yet to not push back. So our entire cultural narrative, which is don't do drugs, which is so bonkers to me, because then we're like, don't do drugs, but it's totally fine to go drink at this bar on Friday night. Or like, don't do drugs, but also cannabis is totally chill. That's my own private soapbox. You guys you don't have to hear about that today. We tell people not to do drugs, but we give such mixed messages around it. And especially for adolescents, it's incredibly damaging. Because what it does is it really sets them up to use substances in the riskiest of ways. And that's part of why we lost so many teens in Oregon to fentanyl. Because we're like, don't do drugs. And they're like, it's not drugs, I bought an Ambien online. But it wasn't an Ambien, right? Yep, that's a big one, that's a heavy one. What else? What other bullet points would we want to add that are specific to adolescents? Yeah.
I think the speaker this morning who was talking about the school policies, like just how schools handle drugs and expelling or suspending, removing kids from the healthier environment and the learning opportunities that school can offer.
Oh, that's such a good one, and I never would have thought of that. So let me see if I can reflect it back. The school policies around like removing kiddos that are using substances or expelling kiddos that are using substances is actually the opposite of what those children need most, which is a healthy community. Yep, absolutely. And my guess is, and I could be wrong, but if we back up just for a second, we have lots of evidence that says not to tell kids not to do drugs. The public health evidence for that messaging is very clear. But what do we continue to do? We tell them not to use drugs, right? We don't set up like big community education nights around how to use drugs more safely. We just tell kids not to use drugs. So I want you guys to see this as a prime way where stigma influences, even though we've got all this like best practices, we don't do it. And my guess is, and I don't know, but my guess is for this, the evidence is clear that kids that are using substances should be allowed to remain in school, but we don't do it. And there are reasons for it. I can also I can think about why you would remove kiddos. But it's just a wonky place where there are so many places over and over again in substance use disorders where the evidence says this, but we do this. It's bonkers to me, and yet not bonkers, because there's very clear reasons for it. Yeah.
I think that this is a stigma about the availability of treatment. It's that there is no treatment for youth.
Yeah.
And so I can think of a recent example where a kid was hospitalized for a month for psychiatric care, was referred to residential. The wait list is going to be until October, November, and this was back in August. So because of that stigma of, well, there is no care, she got discharged with one appointment that was a week later for a much, the lowest level of care.
Lowest level of care.
And so it's like that structural stigma of nothing we can do.
Right.
So
totally.
Just bounce her out.
Right. Yeah. Yep. So the structural stigma of just not building supportive systems of care the way that we would for other medical diagnoses. We're like, yep, month of psychiatric care, SUDS, there's just no openings. We're really sorry. And there's a million reasons for that, right? There's understaffing, there's culturally we haven't put enough value on treatment services for kids. I mean, there's so many different reasons for that, and most of them are going to come back to stigma in one way or another. I see a hand up back there.
And this might cross over, but kids have a drug phase, or they're allowed to explore drugs, and it's either cool to do it or not cool to not do it.
Yeah, that there's a cultural norm that drugs are normal as a teen. Yeah, and I think what we know about the neurobiology is that's a period where you want to experiment. But then we should be talking about experimentation in evidence-based ways, right? Not just saying teens experiment. And then we're like, oh my God, 5 teens died from fentanyl overdoses. And we don't see how those two statements or those two sort of narratives compete with each other. Yeah, absolutely. Okay, I see one more hand, and then we will move on.
This is kind of pre-adolescence, but in elementary school, when kids are so black and white, they're doing the black and white education too of any alcohol is bad. And the kids come home or go to other people and my family's bad, am I bad? It's just, yeah.
Yep, absolutely. It's interesting because you're right. We do younger kiddo education in a way that's really all or nothing. But I think culturally we have failed to then shift that as their brains change. We don't do much more nuanced education around substances as kids' brains change, right? It's something we haven't done the best job of. Okay, so I wanted to highlight a couple things that I thought of as I was putting this together, and we could probably do this for 8 hours. The point here was just to pull out youth specifically and think about the sort of overlapping stigmas and then how stigma is gonna really show up for youth. So some other things that I thought was teens don't really see themselves represented in the media as being able to recover. There's just this idea that it's okay to experiment, but then what happens if that experimentation doesn't go away? I can't think of any representation of adolescents getting into treatment or engaging in recovery. Can you guys? Well, actually, you know what? Euphoria. But other than that, I can't think of any. Yeah. Oh.
A book called Demon Copperhead about a youth in foster care who becomes addicted to opioids in Appalachia and does, as a young adult, get treatment and recover.
Sweet. That is awesome. Now I want to read it. I never will. Oh, it is holding the bottom. It's totally holding the bottom that causes the problem. That is on me. Okay, yeah. So it sounds like a good book. And as a general rule, it's not something that kids are going to see a lot, right? What is reflected back in the media is older people who have hit rock bottom. That's who needs to engage in SUDS care. So that's what teens are going to internalize. And then I think something that we should think about just for a second is how impressionable young neurobiologies are. So the brain is very plastic, especially before the age of 25. And so shame before the age of 25, and I don't know that this isn't evidence-based, I'm just sort of, I think this is likely how it works. Shame and those like cortisol peaks and valleys are gonna be more harmful when the brain is more plastic. That's why kiddos with high ACEs scores have such changed neurobiology in adulthood. It's because those peaks and valleys of cortisol really do a number on those little plastic brains. So we can sort of extrapolate that the shame that is so harmful and actually sort of aggravates the disease of addiction is even more powerful before the age of 25. And then I think we covered the rest. Yeah. So I am not a kiddo specialist. I know very little about kiddos, but hopefully the Stigma review that we have done today highlights the way in which you can take this sort of conceptualization of stigma and how much it impacts SUDS in all directions, and you'll start thinking about youth a little bit differently. Okay, what is about evidence-based practice? What of this is about stigma? Is there anything we can shift? And we'll come back to that in a second. What I want to do next is I want to do your actionable takeaways for today. And this is always really tricky because I've just given you a little bit less than a 1-hour lecture on these really, really nebulous concepts that I want you to carry forward with you as you're thinking about building systems and treating your patients, et cetera. And sometimes that can feel really hard. So I want to give you some actionable things. And the first thing I want to do is I want to give you actionable language. So what we know is that language is a primary driver of increasing stigma, and the research backs this up. And so what I've done is I've pulled out evidence-based suggestions for clinically accurate language for substance use disorders. And when we use clinically accurate language for substance use disorders, we decrease stigma. And as we've talked about, when we decrease stigma, we're actually going to propel people to be more likely to engage in recovery services. So let's go through what the evidence-based says. And I highlight that this is evidence-based because sometimes there's like opinion pieces about words we should or shouldn't use, and I think those are really useful. But this is actually based on pretty high quality evidence, and I'll describe to you guys what the researchers did. What they did is they told the same story hundreds of times, and they switched out a couple of key words when they told the story, and then they asked people how they felt or what they thought about the main character. So, for example, the story would be something like, Edward goes to his medication-supported recovery provider on Friday after he has a return to use. And then they tell the same story to someone else. Edward went to his MAT provider on Friday after a relapse. And then they're like, so is Edward a good person? And what they found is that some words really conveyed sort of a moral goodness and a moral not goodness to Edward. I don't think they used the name Edward. I'm just trying to give you guys an example of the type of storytelling that they did. So this isn't me saying like, I think this word is better. I can totally tell you guys what I think. But what I want to highlight here is what's the evidence-based language? Because I think that's really important. We wouldn't implement an evidence-based we wouldn't implement some like big therapy paradigm that has no evidence behind it, right? We probably wouldn't do that. So we're not going to use language that's not evidence-based either. So let's go through this really quick. Sometimes this can be kind of a complicated graphic. It's actually not super complicated, so I'll try to break it down for you. And if you can't read it, I'll try to read some of it for you. Can you guys in the back, can you see across the top? Okay. So what we have over here is a list of words, and I'll read them off as we get to them. And then across the top, this first column says mutual aid meetings. The second one says in public. The third one says with clients. The fourth one says medical settings. And the fifth one says journalism. So when we go through each term, we're going to talk about where it might be appropriate to use language and where it might not be. We're in a medical setting, right? Are there peers in the room? Yes, we have peers. That's awesome. Okay, so then with peers, things are much, much looser. But in a medical setting, this is the one that we are going to focus on. And I highlight peers and mutual aid meetings. For the most part, we're going to skip this column, mutual aid meetings and peers, because we're talking primarily about working with clients in a medical setting. And so what's an important distinction about that? Why might the words I use in my client's EHR be different than the words that I use when I go to a 12-step meeting or some other kind of mutual aid meeting? Power dynamic, totally. I get to self-identify however I want to, right? I get to tell my story. People in recovery get to tell their story. We get to identify however we want to. But when we are trying to use clinically accurate language that's evidence-based, we're going to do this. So if someone goes to an AA meeting and says, I'm an alcoholic or I'm an addict, chill, that's great. We don't police people's language, but we're going to do the best we can to use evidence-based language as we move through the world. So that brings me to the point that I always try to highlight when I'm talking about this, which is that this is not about telling people how to talk. So, when your client comes in and says, I relapsed over the weekend, you're not going to be like, well, technically, I think what you meant is you had a return to use. Right? Nothing feels worse than when someone corrects your language and misses the tenor of what you're trying to say. It's an awful experience. I am not telling you guys about recovery-based language because I think that you guys should all walk around policing people's language, coworkers, clients, other people at 12-step meetings, etc. I'm telling you guys because I think you should start working internally to use the evidence-based language and model it for other people. You don't have to tell them how to talk, but you model the right thing, right? Don't correct people. It feels awful. Okay, so let's start with the top one, addict, alcoholic. Medical settings, stop using those words. The evidence says that we think more poorly about people when we use non-person first language. This is different. Autistics have said we want to be autistics. We are going to narrate as autistics. But in addiction and in mental health, it is pretty clear that person first language destigmatizes. We don't say schizophrenics. We don't say alcoholics. We don't say addicts. Person with schizophrenia, person with an alcohol use disorder, person with a substance use disorder. Person first, right? The next one says substance abuser. So this one right here says substance abuser. You go over medical settings, it says stop. And sort of adjacent to that, also, we don't say abuse. So what is the concern with saying abuse of substances? The evidence says that it's stigmatizing. Why do you guys think that is?
Has a really clear negative connotation.
Has a really clear negative connotation, right? Who are abusers? Child abusers? People that abuse pets? People that abuse their children? Come on. We don't need to put people that use substances in the same bucket. Are people violent sometimes when they use substances? 100%. But is it a core feature of substance use? No, not at all. So we just do away with the word abuse. And also, it's not medically accurate anymore, right? That's the DSM-4. This is 2023. People engage in risky substance use. We could call it bonkers, right? Like there's all these words for it, but abuse is not something that medically means anything. Okay. Next one is opioid addict. We're going to skip that one. And then let's do the next two and then we'll move on. So then this one is relapse. And if you come over here to medical settings, you'll see that it says stop, which is really interesting, right? It took me years to train myself out of saying relapse. Years. The preferred term, when they told these stories and then asked about the person in the story, the preferred term was return to use or recurrence of use. So we try to avoid the term relapse. And when I'm documenting, I try to get really, really specific because that could mean a lot of different stuff. If I document return to use or relapse, that could mean that someone that hasn't had a drink in 10 years had one drink on Saturday night. And it could mean that someone's seeing me after 3 months of continuous use. What does that mean? It's a word that comes from the 12-step community, but it doesn't have, and I think it's super useful in the right setting, it doesn't actually have a lot of medical utility. Return to use or relapse, however you call it, what does that mean? So I would try to say something like return to use of methamphetamines 3 days, use of methamphetamines times 3 days, no use the following 2. I would try to be really, really specific because we've got these sort of language shortcuts, but especially around substance use, we want to be very, very specific. Okay, I see you guys starting to I
just had a quick thought on that, sorry. Relapse is a hard one for me to not, and return to use sounds clunky. So I just say patient used methamphetamines on Saturday and Sunday, and then, going really specific, because for whatever reason, return to use is clunky and relapse is no, we're not doing that anymore.
Yeah, found a workaround where you just don't say relapse, which is the most important part. Relapse has negative connotations, totally. I had until 1:30, is that right?
Yes, but you can go until 1:40.
Okay. I have to pick up my child at school, so I can't, but I just wanted to make sure. Okay. Thank you. Thank you so much. Okay, do you guys have any questions about the language piece? I see a hand back there.
How do you, so I know you're a medical provider, and I know you're super aware and informed of a lot of things that maybe other medical providers are not, and I also am aware of where you work, which I don't think is much of an issue in terms of providers sort of not using that similar language. But how do you navigate medical providers that continue to use the language even after some cues from you or just reading your notes in general? And I don't think it's malicious, but they're rigid and have their own understanding of that. How do you navigate that without becoming kind of the, oh, here it comes again person?
Well, I have to be transparent. Well, first, you're my new best friend. I love this question. Secondly, I'm always that person that oh my God, here's Lydia again. She's going to tell me something I've done wrong. So I've worked really, really hard to not do that. Turns out, though, that I have the skills to not be that person that's oh, here we go again. It turns out I actually I've been studying that for a long time, and I think most of you guys have too. What is it? When we want people to change their behavior?
Motivational interviewing.
When we want people to change their behavior and we don't want to be a dick every day about it, we know how to do that. This room is well trained in that. And it's so grounded in love. Providers keep using those words and I'm gosh, I really feel I'm harping on you and I'm so sorry to bring it up again, but, just the evidence really says that this is useful. Let me know how I can support you in implementing that in your practice. Or I heard you say that again and, we don't have to have a big thing about it, but let me show you this paper on this. And I might do some sort of provide elicit. Hey, has anyone ever talked to you before about how this word is stigmatizing? Well, what the evidence says is this. Do you think that's going to be hard for you? So we've got all these tools for motivational interviewing that are super useful. And the sort of core tenets underneath that I think are the most useful is just humility and collaboration. Just when you tell someone and you've told them the 10th time, you're just still humble about it. And I know that's probably is an overly simplified way to answer your question, but it really is something that, as a medical leader, I think about a lot. How do we make these tiny cultural changes without annoying people and without turning them off from us? And it's all about humility and collaboration. And I think that's especially true with language. What other questions do you guys have with language? Any other questions, thoughts?
Sometimes I have concerns that, language shifts rapidly, and the constant change in language may reflect different time periods and how people view it, and may also change in connotation in many of the way the medical terms have been used as slurs against many people, right?
Yeah, absolutely. So trying to stay sort of up to date on medical terminology.
But also changing it too much can also be a problem, right? Yeah.
huge major changes.
Yeah, or quickly. It's like, oh, that was last year's. You're using 2 years ago. Yeah.
Yep, fair enough, fair enough. Yeah, the concern with there just being sort of change overwhelm. And again, I think this is a time where like we just model what we know to be best practices, just like we would with any other intervention. We model what we know to be best practices and we support other people in doing it. All right, so that's your actionable takeaway number one, language. And you can find this, a lot of times people want this graphic. If you just Google recovery dialectics, Robert Ashford, he's an amazing researcher. He's a clinical social worker in recovery himself, done a lot of really good recovery work. You just Google his name and then recovery dialectics, and this comes up. And I always hang it wherever I work so that people know why I'm using the words I'm using. Because people are often like, what do you mean by return to use? And so then it's a useful way for me to explain, well, here's why I do that. So here's my second actionable takeaway. And you should have sort of heard me say this before now, but in case it hasn't been really clear, second to language, the one thing that I would want you to do on a regular basis is ask yourself, this thing I'm doing or this thing I'm promoting or the way that I'm going to have this conversation, is this grounded in the stigma or is this what I know to be best practices? So much of what we do is grounded in stigma when best practices for substance use disorders really reflect over and over again collaboration and mutuality. So motivational interviewing is all about collaboration and mutuality, and yet when there's people that are using substances in the clinic right in front of us, we often don't do that, and we sort of fall back on stigmatized narratives about who people are that use substances. So just keep asking yourself, and I can't answer that for you, but the question I want you to ask yourself over and over again, would I do this if I was aligning myself with evidence-based practices? Is this something that I would do? Or is there any chance that stigma is infiltrating my mind right now? Keep asking yourself that, and you will be, I think you'll find that it's a really interesting exploration. And you'll learn some new things. Thanks, you guys. I went over. We have 6+ minutes for questions. My apologies. What questions do you guys have?
Can I ask you a question about pornography? I'm curious, when we talk to young people about pornography, we're not trying to say pornography should be like real life and we need to change the porn industry to be accurate and representative. We instead talk to them about this was made for adults, this is made to make money, and it doesn't represent real life. So let's analyze media, right? And I think what you were saying earlier about representation in media, is that the goal? Like, should we be looking at Disney and these giant companies to show positive representations of recovery, or should we be teaching young people to analyze what they're watching to know that that's not the full story or that's not reality? Because I don't know that Fox is ever going to say the recovery story, that's really interesting, people want to watch that. I don't think that's interesting. Like, I don't think people are going to be tuned into that story as much as the person that is the comedy or is the stereotype of what someone with substance use disorder is.
Okay, I love this question. I feel like you have probably thought about the answer way more than I have. But my gut response is both. Like, part of the conversation of, hey, when you're watching porn or you're watching Fox, here's the lens it's coming through. Wait, what was funny about that? You guys are dirtier than I am, I think. Okay, when you're watching XYZ, there's a couple things to be thinking about. How is this going to influence you? And why is it represented this way? So I guess really my answer is, can we have conversations with kids about both? Because I think representation is really important, and people need to be far more media savvy. And to me, those feel like very similar conversations. But that's like totally just thinking about it just in this second.
And isn't the line, it's not interesting, that's structural stigma?
Yeah, it's not interesting. Yep, absolutely. Yeah.
Examples of where you've seen structural stigma really get sort of like torn down and communities come together and say, we're going to work on this, like we're going to change it.
Yeah, I think I have. And when I say I think I have, what I mean is that I have seen entire healthcare systems pivot how they think about supporting people with substance use disorders in a 5-year time span. So it's totally doable. Do I think that those of us in this room are going to like completely transform the way that Oregon sees substance use disorder? No, not at all. But I think that there are ways in which we can influence structural stigma. I mean, especially because we're in this amazing cultural moment. We are in this cultural moment where the president of the United States is being like open and supportive about a relative with a SUD. That's a first. We are in a cultural moment where the president of the United States is endorsing evidence-based practices for substance use disorders like harm reduction, which we've never seen before. So like if there's ever a time that we could make a big change, I think we're in it. Does that answer your question? Not really. No, it's good. No. Okay. It was like really inspiring, but didn't actually answer the question. Okay, cool. Oh, okay.
Is it stigma or malpractice or something that's keeping, say, the psychiatric hospital mental health setting from starting MAT? Because, I feel like that's our agenda being here today. It's like, we're too late in the system, right? It's got to start when they've got them at the hospital. What's in the way? Do you think as a medical person? You're a medical person. What do you think is in the way?
So the question is, what's in the way of the major hospital systems starting medication-supported recovery when someone is in their care? And is that specific to youth?
Well, for me.
I think stigma is a huge part of it. Duh. I think stigma is a huge part of it. I'm sure you guys could all guess that was my answer. And I think we're on the precipice of a huge shift. And that stigma, something I've been thinking about a lot lately is just why aren't we starting methadone like all the time? Fentanyl just doesn't respond as well as to buprenorphine as it does to methadone. But we have so deeply stigmatized methadone. Clients stigmatize it, we stigmatize it, medical providers stigmatize it. And we have to make changes. And it's incredibly hard because that's built in, some of that stuff is built in at a federal level around OTP regulations. So it's tricky, and I really do. I know I just sound overly hopeful probably and sort of Pollyanna-ish, but I really think that right now is the moment when like big hospital systems are going to start implementing medication-supported recovery. Yep. Thanks, you guys. I'm going to go now pick up my kid from school.